Hello, it's Dr. Rapala, and we're going to talk about governance and culture, reporting and root cause analysis today. And there's a slide deck in your materials, and I just want to hit upon a couple of the high points in this particular area. It's an area that you can talk about for several weeks. It's an interesting area, but for our purposes, we're going to only highlight a couple things today. First of all, if you're a leader, you have to figure out how to operationalize all of these quality and safety things that we've been talking about, whether it's an initiative or the science. So not only do you have to make sure that it's operationalized in your organization, you also have to enable the board and your employees, fellow employees, to see um, how it's working within the organization. So that's a little bit of a challenge when you think about all the different things that we've discussed. And usually there'll be an org structure. Most often there's a board of directors. The CEO usually reports to the board of directors, whether it's a health system, could be a nursing home system, long-term care facilities, it could be a clinic system. Most of those structures have a CEO, hospitals, clinic, and a medical group. Occasionally, you'll find some sole practitioners who just own the practice themselves. And so usually there's no board and they track different things different ways. But most healthcare systems, you'll find org structure. And it's typical to see hospitals, clinics, a medical group in a healthcare systems. There's also finance, human resources, legal, regulatory compliance. The board comes in usually quarterly, and over the course of a day, maybe a day and a half, the CEO and other staff members have to illustrate what the hospital is doing. Usually objectives are set and that's reported off on. There might be some different initiatives, but there's not a lot of time because in addition to quality and safety, you're talking about finances and other things. And actually, until the last, I'd say 15 years, there was criticism, there's articles in the literature that mostly healthcare systems talked about finance and not quality and safety. And now I would say most do. There are some recent articles that show that a good portion of healthcare systems do report those kinds of things. In other areas, it may not be as prevalent. But for the most part, for healthcare systems, this data is brought forward. So the question is what to bring forward. We've looked at all of these things, all of the tactics. You have the fair and just culture, maybe disruptive practitioners, performance improvement initiatives. How do you sort it out? And actually, this is um, safety and quality initiatives, and it's bucketed into some high reliability infrastructure that David Gaba, who's an anesthesiologist, suggested. He says you have to have systems and structures, a culture of safety, have to learn from it, and there has to be training. So this is just one way to organize it. Then you have to figure out who does it and then what to report. So again, the CEO can't do everything, so usually delegates these tasks and the different science to different people for departments. And then measures are prioritized. There could be regulatory requirements, or there could be an internal issue that the organization's tracking. And usually these key metrics are put on a quality and safety dashboard. So here's an example of one. It's from the National Health Service in Great Britain. But it's pretty typical of a dashboard. And sometimes they're just graphs. Sometimes they have, these little dials. There's all different ways to report them. Sometimes there's just numbers. This green, yellow, and red light is a pretty common way to illustrate if you're making your benchmark. So in this organization, they're tracking MRSA bacteremia complaints and some other things, see falls assessment, and then usually every floor in the hospital will track falls. And you probably have seen some of those quality improvement initiatives, and it rolls up to the hospital and then the system, and it's tracked. And if there's a problem area, it can be broken down because board members do ask questions. Usually once a year, experts in the system will get together and decide what metrics to track and what to prioritize. And for example, if people are doing well in a particular area, it looks like they're doing great in patient experience. It looks like they're doing pretty well for MRSA. They might want to the next year retire that metric and just check on it periodically and introduce a new one that has some issues. So again, it's a way to prioritize, and keep in mind that finance would have their own set of indicators, HR, other places. So the board has to look at these things, within the course of a day and try to understand what's going on in the organization. So it's a pretty big responsibility to figure out how to translate that knowledge. And you never want anybody to be surprised by anything that's coming out from the organization. So leaders do have to establish and sustain a safety culture. Culture, even if you talk about culture, doesn't mean you have a good one. And there's some examples in the literature about the checklists, the surgical checklists that worked in one place but not another. And there's a case study you can take a look at, and sometimes you will see both organization A and organization B in one particular organization, just depending on the issue and the people involved. So it's always a challenge to make sure that everybody's responding in the best way. There's just lots of things that go on in a healthcare system. There's a culture on survey, and I won't go over this in detail, except to say even the areas of strength. So people see teamwork as an area of strength. That means still that 18% of healthcare workers who responded here think maybe there's an issue. And areas of improvement, this is pretty consistent in most hospitals. Non-punitive response to error. Even if you feel you have a non-punitive environment, often those on the front line will feel it's punitive because they're talking about their mistakes and worry. Handoffs, transitions, and then staffing. These are pretty consistent in most organizations. The Just Culture algorithm is something we'll take a particular look at, and most healthcare systems use some version of this. So we know most errors are a result of a systems issue. When this came to healthcare, people worried that this would translate into people with performance issues would never be held responsible for their actions. And so this particular algorithm was adapted from Jim Reason, who's an engineer. And it's a guide to how to understand human action in a particular incident. And there's all kinds of these things. Some are proprietary. You can find one on justculture.com. They have a free version, but the paper one costs $25. Some are free, and the one we're going to look at is from England, the National Health Trust. They're all the same. And it should be endorsed by leadership and used by all of the organization, including human resources. And many times for incidents that are complicated, it helps to get together and talk through the algorithm to make sure everybody's looking at it the same way at the end of the day. There's lots of different opinions. And if we were to bring a particular incident and discuss it in class, there would be people that have different points of view, and seeing everybody's perspective is always useful. So let's take a look at the algorithm. First of all, if it's a criminal act, that puts it outside the algorithm in a different bucket. People meant to do it. Most of the things we talk about are things that people do unintentionally. So if you didn't mean to do that med-error, if you didn't mean for that patient to fall, which is 99.9% of everything, it goes in this algorithm. But criminal acts is outside the scope of this. So you can see here is the NHS, the National Health System Just Culture Guide that they put together. Was there any intention to cause harm? If the answer is yes, take it over to HR and legal. They'll take a peek at it there. Were there indications of substance abuse or ill health or mental health? Maybe you were prescribed a medication and didn't anticipate some sort of reaction, or maybe there was diversion. There's usually some institutional policies you have to go through in those cases. I will say that actually, it's been my experience anyway, that that doesn't happen very often at all. Actually, not often. I mean, you always have to consider it and look at it, but it's usually not the case in the things that we look at. And then another question that's super important is were there protocols, practices, policies in place? And were they workable and in routine use? And this is what trips up a lot of incidents because sometimes we have policies and procedures. You might have a unit policy, you could have a practice guideline, you could have an order set, you could have a system policy. And sometimes they don't all agree, just depending on how organizations are. Maybe an organization is just merged and it doesn't jive with the system policy yet. Maybe a unit has had this policy in a loose leaf binder for 15 years, but oftentimes it'll be a challenge to figure out what the particular policy is. And then once you decide about that, did the individual depart from these protocols? And sometimes it's okay. I mean, if you have to give the medication per policy within a half hour before or after it was ordered, but you have a patient coding in the next bed, you have to prioritize, and usually the patient coding will get the care and the person might get their med a little bit late, and that's okay. That's why you have to look at context. Every now and then you will find somebody who does know the policy and decides not to do it. Maybe they think it's a better way of doing something. You do find that, and sometimes you ask them, did you know this is a policy? And they'll say yes, and they elected not to do it. So, but most of the time, there's an issue with the policy, maybe education of the policy, all sorts of things around there. So that's an area to take a look at too. And then the substitution test is very important as well. So if somebody coming the next day could make the same mistake, that really means that it's pretty clearly a system issue. And that's why often firing the person who made the mistake won't work, because it doesn't fix the system. And also, did all of the individuals have the proper training? Sometimes you'll find that there's training and maybe they haven't had it yet. Maybe they put the policy in place before they did the training. Or was the leadership supervising that particular team member? Sometimes the team member doesn't even know they're supposed to do something. So these are all really important questions. And then were there ever any mitigating circumstances? So sometimes you'll have something that is just highly unusual. And actually, if you look at COVID-19, we didn't probably follow a lot of policies right off the bat, and a lot of policies were changed even by the government because COVID-19 was a mitigating circumstance. So if you look at all of these things, and actually if you look at this, when you get to 3, 4, and 5, it's usually pretty clearly a system issue. But again, a great document to walk through with colleagues on the floor. The next thing I want to talk about a little bit is, and just a little bit because I think we just have 45 seconds left, is the cause and effect diagram. This is a way to graph out something that happens. So here's the error, the long-term results time, and then you look at all of the things that happen. So here's a secretary with a heavy workload who is unavailable when lab called. The environment, it's just a graphic depiction of maybe the steps that went wrong. And these should be all things that went wrong. So here's the materials, the lab supplies were unavailable or spoiled. The equipment, there's a malfunction. capacity was down. All of those, this is a